So now we're going to look at the apical four-chamber views. So you to get your apical four-chamber views, you take your transducer up, and remember, when you're going to do your scanning, you have to put a little gel on the transducer, the tip of the transducer. You put a little gel, and that gel serves multiple purposes. One is it allows you to easily glide across the patient's skin, and not only that, it provides a if you want to call it a fluid, so that the ultrasound wave can travel from the transducer across this gel substance, which it has sort of have the consistency of tissue. Um, so because it has a consistency similar to tissue, then the speed of sound in that tissue is gonna be faster than the speed of sound in here. So when the sound wave hit this gel, it's gonna speed up. If you didn't have the gel there and you're talking about just air, it would not, it would have been slowly traveling. Remember, the speed of sound in here is 331 meters per second, whereas in soft tissue is 1540 meters per second, much faster. So the function of the gel is multifactorial. So you're going to position your transducer now to get your apical views. And the first one we're going to get is the apical four-chamber view. So to get the apical four-chamber view, and again, remember when we talk about the apex of the apex of the heart is usually, in a normal individual, it is usually at the mid-clavicular line and about the fourth or fifth intercostal space where those two lines sort of intersect. So that is the usual position for the apex of the heart. However, you can put your finger and feel where the apex is. And again, the apical impulse will be, lifting your finger upwards. Okay. If the patient's heart is enlarged, then that position is going to be more lateral, and sometimes inferior. So, but if it's a normal individual, it's usually the mid-clavicular line and the fourth or fifth intercostal space. So what you're going to do, you're going to put your transducer where you think the apex is. And usually at the mid-clavicular line and the fourth or fifth intercostal space. The marker that's on the transducer, you're going to position that to about the 4 or 5 o'clock position, and you're going to tilt and adjust to get the image that you're supposed to get. So knowing where to position the transducer is very important. Remember now, it's just an approximate position. You still have to adjust and manipulate to get the image that you're supposed to get. So in your mind's eye, you need to know what image to get. And okay, so from that apical position, this is the image you're supposed to get. The heart should be standing straight up. The heart should be standing. So this is your transducer right there. The heart should be very upright like this. You have to know the structures that make up the apical four-chamber view. Again, everything we do in when we do echo is either systole or diastole. Systole is between the onset of the QRS and the end of the T wave. In systole, the mitral valve is closed, the aortic valve is open. In diastole, the mitral valve is open and the aortic valve is closed. You can see the mitral valve open here. So you have to know the structures that make up the apical 4-chamber view. So these are the structures. The LV cavity is right here. So LV cavity. The mitral valve. This is the anterior leaflet of the mitral valve. Posterior leaflet is right over here. This is your left atrium. This little structure right here is your descending aorta. This is the descending aorta. Descending aorta. This is your atrial septum. This is your right atrium. Your tricuspid valve. So this is your septal leaflet and your anterior leaflet. Okay. This is the right ventricular cavity, and this is your ventricular septum. So these are the structures that make up your apical 4-chamber view. So remember how to get it. Transducer is at the apex, which is the mid-clavicular line and the 4th or 5th intercostal space. The marker is towards the 4 or 5 o'clock position, and you're going to make minuscule adjustments to get an image looking like this. All right. Now, to get the apical 2-chamber view, so you're in the apical 4, to get the 2-chamber view, you're going to rotate your transducer counterclockwise, not clockwise, counterclockwise. You're going to turn it in the opposite direction, and you're going to adjust it to get an image looking like this. So this is the image you're shooting for. This is your inferior wall right here, and this is the anterior wall. LV cavity is right there, the mitral valve is right there, and this is your left atrium. Okay, anterior wall, left ventricular cavity, mitral valve, left atrium, inferior wall. Knowing these different structures that make up the different walls is very, knowing the structures in the different views, very important, okay? Now, to get your apical 3-chamber view, so you're in the 2-chamber view, all you do, you turn it counterclockwise just a little bit more. And again, these are minuscule movements. You're not gonna make any big movement. So you move you turn your transducer a little bit more counterclockwise, and this is the apical 3-chamber view. Apical 3-chamber view, because now you can see the LV cavity, your left atrium, you open and you see the aortic valve right there, and you can see the ascending aorta right there. That's why we call it the apical 3-chamber view. You have to know the structures that make up this view. This is what we call your anterior septal wall, LV cavity, left ventricular cavity, your aortic valve is right there, and ascending aorta is right there. That's your left atrium. This is your mitral valve, and this is going to be your anterior mitral leaflet. Posterior leaflet is down there. This is your inferior lateral wall. Okay, apical 3-chamber view. So there is something we call the apical 5-chamber view. So all of these views, you have to start with the apical 4-chamber view. All of these views, you have to start with your apical 4. So remember your apical 4, the mid-clavicular line, 4th or 5th intercostal space. The marker or pointer is towards the 4 or 5 o'clock position. You just make a little adjustment to get the 4-chamber view. To get the apical 5-chamber view, from the 4-chamber view, you tilt the transducer just a little bit downward. Very, very faint downward movement. And that's all it takes. So these images are not difficult to get. You have to practice them, however. You have to practice this, and that is why, you have to do scanning and you have to practice. So when you tilt the transducer downwards, you now open up and you can get the aortic valve is right there. This is your left ventricular flow tract right there. The ascending aorta is right there. So a simple downward movement of your transducer, you'll get this view. Again, you have to know the structures that make up your 5-chamber view. So again, your anterior mitral leaflet is right there. Posterior mitral leaflet is right there. Anterior mitral leaflet, posterior mitral leaflet. Now, your pulmonary veins, there are, remember from your anatomy, there are 4 pulmonary veins. They all drain into the left atrium. You have 2 on the right side, 2 on the left side, 1 upper and 1 lower. So this would be your left. We say lower, this is actually upper. So this would be a left upper and the right upper is right there. So these are mislabeled. So this is your left upper and right upper, not lower. These are pulmonary veins that drains into the left atrium. This is your aortic valve. Okay, aortic valve is right there. That's your anterior mitral leaflet. Okay, so this is your apical 5-chamber view. Another structure you can see is the moderator band in the RV. Remember, this is the right ventricle. Moderator band is right there in the RV. So this is your apical 5-chamber view. Very important view. So these views are very important. These are the standard views. So, all right. So another view is the subcostal view. And with the subcostal view, the transducer is positioned in just below the xiphoid, in the subxiphoid area. Subxiphoid area. So your transducer is positioned. So you see the importance of knowing the anatomy because you have to know where these anatomical locations are. So in the subxiphoid, for the subcostal view, transducer is positioned in the subxiphoid area. The marker points towards the patient's head, and you're going to get a view. You're going to get something looking like this. Again, remember, this is your transducer. This is your inferior vena cava, big blood vessel. This smaller one is your hepatic vein. The hepatic vein drains into the inferior vena cava. Okay? And then, of course, the inferior vena cava drains into the right atrium. Right there. Subcostal view. Okay, right atrium, hepatic vein, inferior vena cava, and measuring the width of the inferior vena cava is very important. So you usually measure it just before where the hepatic vein enters the IVC right there. So measuring the width of it is important. So so this is, if you manipulate your transducer a little bit more, this is another subcostal view where you can see the right ventricle right there, the right atrium is right there, tricuspid valve is there. This is your ventricular septum, atrial septum, LV cavity is right there, left atrium is right there. This is a very important view because if there's a problem with the septum, ventricular septum, or your atrial septum, you can see that clearly. Also, if the patient have pericardial effusion, this is a very important view to look at the pericardial effusion. So overall, this is a very important view. Okay, subcostal view. That's your liver. Okay, this is the liver over here. So this structure is the liver. The right ventricle, ventricular septum, left ventricle, atrial septum, left atrium, right atrium. So remember now, the inferior vena cava runs through the liver. The hepatic vein also runs through the liver. So remember from the view here, this is the liver, this is the liver right here. The inferior vena cava runs through the liver, and the hepatic vein also runs through the liver. So the last standard view that we're going to look at is the suprasternal notch view. Suprasternal notch. So you know where your suprasternal notch is located because you did anatomy. The transducer is placed in the suprasternal notch area, and the marker points to the patient head. You're going to turn the transducer to the right, and you're going to adjust it, and this is the image that you want to get. You want to get something looking like this. So it might not project clearly, but you can see this sort of arch. Okay, so you can see this darkened area that comes over like that. So this is our ascending aorta. The aorta ascends. This is the ascending aorta, the aortic arch, and this is descending aorta. So this is what you're going to get. The different structures that make up this view, you have, this is your right pulmonary artery right there, right pulmonary artery. Now coming off the aortic arch, you have to know the blood vessels that comes off the aortic arch. Over this side, we have the innominate artery, and the innominate artery divides to the right subclavian and the right common carotid. Right over here, we have the left common carotid and the left subclavian. So again, this is suprasternal notch view where you have your ascending aorta, aortic arch, descending aorta, right pulmonary artery, and then the branches that comes off the aortic arch. Again, when you start your scanning, your instructors will it's gonna be much clearer, and they'll show it to you. Okay, so those are the standard views. So once you master these views, I mean, 90% of your scanning is complete. So I recommend that you go over these multiple times before you start scanning. Multiple times before you start scanning, because when you put that transducer on the patient chest, if you don't memorize everything is just going to go like that. Okay? But try and and develop a protocol, go over the views, understand the structures that make up the views, and on Thursday, what we're going to do, we're going to go over some normal studies, and we're going to incorporate everything, and then hopefully on Saturday, you guys will start your scanning. Okay. All right. So on Thursday, it's going to be 7:30 U.S. time. In Jamaica, 6:30. Okay, so 6:30 Jamaican time, 7:30 U.S. time, and we're gonna go over some more scanning views. Okay, all right.